He who reads leads to follow her heart's desire.
Good evening to you, my beautiful audience. This evening, we are here to discuss dementia, its management and care. As someone who recently experienced a relative being diagnosed with the disorder, I know how frightening the diagnosis can be, especially when we really don't know the facts. Each of our panelists here this evening, which I will introduce shortly, was invited to help us, all of us, to better understand dementia. And in doing so, will be better prepared to accept, as I say, to accept the diagnosis and learn to live with it, manage it, care for the individual who's living with the disorder. So I will introduce our panelists here this evening. First, I'd like to introduce Dr. Karen Phillips. Dr. Karen Phillips is a consultant physician and former head of the Department of Medicine at Kingston Public Hospital. She holds a DM in internal medicine from the University of the West Indies, Mona, and a Master of Science in Diabetes and Endocrinology from the QMLU in the UK. Our second panelist is Miss Rochelle Amor, and she is a researcher and NGO on the STRIDE, and you will hear more about STRIDE when both of those ladies speak. And as well as a co-founder of the Age Caribbean Consultancy and collaborating on dementia research at the King's Old Age Psychiatry Unit at the Institute of Psychiatry, Psychology, and Neuroscience. Moving on to our third panelist, Miss Janelle Robinson. Ms. Robinson is a mental health counselor and researcher at STRIDE Jamaica. Her work and interests revolves around understanding psychological trauma and the integration of culturally and conceptually valid assessments. In her work in New York, she contributed to the enhancement of youth justice agencies and worked closely with young persons and their families in the capacity of court advocate and youth mental health provider. Then we move on to Nurse Terrian Bennett. Ms. Bennett is a licensed practical nurse with over 10 years experience. Nurse Bennett is currently working at the Changes Home and Daycare Center for the Aged as a supervisor. Her favorite Bible scripture is Psalms 16, verse 1. Preserve me, O God, for in thee do I put my trust. And of course, to balance what we're doing here this evening, we have Mistress Penny Green Daly, who is actually a caregiver. Mrs. Daly is a secondary school teacher who has a passion for life and just love to live. That's the list of our panelists here this evening. Dementia is something that we hear floating around, and oftentimes we hear dementia and we hear Alzheimer's. Now, Dr. Phillips, what really is dementia? And is it different from Alzheimer's by confusing Alzheimer's with dementia? And then what are some of the symptoms to really look out for?
Okay, so that's quite a lot you're asking me in one sentence. But, I think my favorite definition for dementia really speaks to an acquired global impairment of intellect, memory, and personality in the absence of loss of consciousness or impaired consciousness. So it speaks to the fact that there are multiple dimensions which are affected in these individuals who appear alert and coherent. Basically, well, not coherent, but alert and engaged to some extent. Alzheimer's is just one type of dementia. There are a number of types of dementia. Alzheimer clearly is the most common, so it's the one that you'll hear about the most. But in addition to Alzheimer's, you have other, I mean, I don't really want to get too scientific, but you have different types. You have, depending on the area of the brain which is involved, the frontoparietal, you have Lewy body dementia, you have Parkinson's with plus dementia types, and so on. But outside of that, you also have acquired issues such as vascular dementias, which may occur in persons who are more at risk for or have had strokes or other vascular issues involving the brain. And then there are some acquired causes which are technically reversible causes and may mimic dementia. So among these, you will have infectious types of issues. You may have persons who are depressed. You may have persons with vitamin deficiencies like B6 and B12 deficiency, etc. So quite a number of causes, but as we say, we speak more commonly of Alzheimer's in terms of an irreversible cause of dementia.
Okay, thank you very much for that. So based on what you just said, you said that there's a particular type. So we hear in general that when someone has dementia, there is no way of having it reversed. But you're saying that there is a type where
I'm saying that, yeah, right. So I'm saying that there are some causes which mimic dementia. So there are some conditions which mimic dementia. It's very, very important, which is why when a person is given a provisional diagnosis of dementia, they're usually referred to a physician who can then do the regular tests to look at dementia, so some screening tests that we will use, but also to rule out other organic or medical conditions that can mimic dementia. And notable among these are like depression. As I said, there are vitamin deficiencies, B12, B6 deficiency. There are persons who imbibe alcohol heavily. There are persons who may have infectious disorders affecting the brain, so encephalitis, encephalopathies, that kind of thing. Persons with hormonal problems like thyroid hormone issues, persons with syphilis. So this goes on. So there are a number of conditions that need to be excluded before we think that this really is a primary, dementia as we understand it as a primary brain disorder. And of those, as I said, you have a number of them. So you do have Alzheimer's being the one which is most commonly spoken about and understood, and maybe not very well understood, but referred to. But you have other types, so which are not as common. Some of them are degenerative conditions affecting the brain, Lewy body dementia, etc.
Okay, so I have a follow-up question to that then. At what point do you actually draw the line and seek medical assistance? Because we're accustomed to forgetting things. I forget things. I'm sure you forget things. I'm sure people in the audience forget things and start to think that, wonder if this is happening. But there is also, regular forgetfulness. But at what point do you really think that we need to go beyond just thinking that everybody forget?
So as you clearly put it, that is true. We all forget our keys. We forget our kids' names. Sometimes we call them, mix up their names, etc., etc. And that's quite familiar. And persons always, usually get very concerned that, oh my God, I'm forgetting these things. But when it gets to a point where there is impairment in intellect, impairment in judgment, where it is affecting your quality of life or your daily existence, then it's a matter for concern. So if you notice that yourself or a loved one, so usually it would be, the other day I had a patient who came to me, and she came on behalf of her friend, because initially they thought the friend, they were joking around that she was always losing something, she can misplace her key, she misplaced her phone, all of these things. She has her phone in the hand and can't looking for the phone. It happens to me too. But then they became concerned when she started to demonstrate issues related to hygiene, when she started not remembering conversations, when she started not remembering certain family members, And all of this was now getting more progressive and interfering with her quality of life. And at that point, there was an intervention. So I would say
Okay.
once it begins to affect your quality of life, it's interrupting your daily activities and your functioning. Yeah.
Thank you very much for those responses, Dr. Phillips. Miss Amor, oftentimes we hear about persons living with dementia. We quickly assume that is somebody that is very old. Can you classify what age range is considered old? And is it a fact that only old people can actually live or experience that disorder, dementia? As the age person here this evening, help us here because I want to understand.
Sure. So I'll tackle the first part of your question.
Right.
What exactly is considered aged? At what point do we need to start worrying? And as we know, getting older is a personal, very individual experience. So depending on our circumstances, our health status, um, you know, basically our everyday lives, that will look different for different people. But there are, certain points in life that we may decide, okay, 50 plus for certain reasons. So for example, you can join the CCRP, Caribbean Community of Retired Persons, at 50, because that is, the earliest that a lot of people might retire. Most people might retire between 60 and 65. And so the government will consider you older or aged at that point. And then in gerontology, we consider what we call the oldest old as 80 and over. And these people will usually require specialized different kinds of social and healthcare supports. So to answer your question, there really is no point at which you need to wake up and say, okay, I'm 60 now, I need to start worrying about dementia. However, age is the biggest and most important risk factor when it comes to Alzheimer's disease, for example. But just remembering what Dr. Phillips said, there are many different kinds of dementias, and there are many different factors that might be affecting this change in our brains. So it might be brain damage, for example, a car accident, which can happen to anybody at any point. There are also certain dementias, Lewy body dementias, for example, that may be associated with having a stroke. That might be, someone in their 50s, their 40s, those people can have a stroke as well. Even though it's most common in persons who are in their late 70s and 80s, the point is that there are many different kinds of dementias. And so some rarer forms of dementia may affect persons who are not really considered old, i.e.,
Okay.
over 50. So it really depends. But it is important to remember that age is a strong risk factor for Alzheimer's disease. We need to take care of our brains, especially as we start to get older.
So as you mentioned that, two things. One, as you said about the age, depending on your lifestyle and how you treat your body, etc. And I find that in the banks, when you have senior line, the senior lines, the age starts at 55. And sometimes I say, oh my God, I soon be able to join that line. So that is very important. Thank you very much for that. Miss Robinson, is there a test to determine dementia? You can test for high blood pressure, you can test for diabetes, you can test for so many other things. Is there a test for dementia?
Right. So I think Dr. Phillips touched on this a bit earlier as well. So there's no singular test, but just bearing in mind within our culture, within the society, the first point of interventions for persons living with dementia is usually the GP, right? But one thing to also point out is that global research, including within the Caribbean, has shown that many healthcare professionals, they still believe that dementia is a normal part of aging. and it is not a normal part of aging. And I won't repeat what Dr. Phillips said because she beautifully delineated the two. But because of the lack of knowledge, it is really important for us to prepare questions as well when we go to the doctor and, do our doctor's visit. And we can put a link in the chat for some questions that persons can ask. So what usually happens in terms of testing and overall assessment, because it's a holistic approach, a thorough physical examination should be the first step, really, to rule out things like infections and so forth. And, the doctor may review the patient's entire medical history. The doctor may administer a dementia screening test or a cognitive test. And, that test would really look at memory skills and just thinking ability and orientation, a little with what Dr. Phillips said. And then what the GP may do is to refer the person living with dementia, suspected to living with dementia after provisional diagnosis, to a psychiatrist or a neurologist. And from there, they can get a CT scan or an X-ray so that we can see the activities in the brain to detect of any abnormal activities. And then in terms of other tests, the doctors may do blood tests just to ensure that, the symptoms that the person is exhibiting is not due to anything else. We spoke about thyroid functions or other deficiencies. So really, it's a series of tests that are conducted for the person for you to confidently say that this person has this type of dementia.
Okay, thank you very much. I'm learning. And just to continue with this line of argument, Dr. Phillips, is there an association with dementia and lifestyle diseases or the regular communicable diseases? Right. So if I have one of those, am I going to get dementia?
Well, not necessarily, but we did speak about vascular dementia. So vascular dementia really refers to dementia which occurs on a background of recurring strokes, for example. And so if you, by extrapolation, yes, we do know that the risk factors for stroke would include not just aging, but also hypertension, diabetes, high cholesterol, so non-communicable type issues, smoking, etc. So by proxy, yes, lifestyle can affect your risk factors for development of stroke, and a history of stroke or multiple strokes can lead to vascular dementia.
Wow. That sounds very frightening, and this is why we really need to take care of ourselves. And Miss Moore, as you mentioned earlier, I had a mental block a while ago because there was something else I wanted to speak about, so I forgot. So right in the middle of this conversation, I forgot something. What I wanted to follow up with was the fact that just yesterday, when I sent out the flyers, someone called me and we were having a dialogue, and the person said that they could not believe that my relative is now living with dementia because they thought that someone who really gets dementia is someone who is very intellectual, who do a lot of studies, who have to think very hard, do the very hard jobs, the scientists, the professors, etc. What do you say about that?
Well, first of all, I just want to thank Dr. Phillips for her contribution, which actually reminded me that I misspoke earlier when I said dementia with Lewy bodies is associated with stroke. That's vascular dementia. And I was thinking about Parkinson's disease. So it's a good thing we have all these professionals in the virtual room. Yes. But when, that's an interesting question, because I think, when it comes to mental health in general, brain health, I think that some of us might assume that that only happens to certain kinds of people, and that's just not true. Some of the risk factors around developing dementia, as well as other disorders, include things like stress, include things like lack of sleep, include things like, what the doctor always tells us to do, diet and exercise, and, managing your daily life, taking care of yourself, self-care. We've heard so much about self-care, especially during this pandemic. Those things are very human. And whether or not you are an intellectual or a professor, or, a well-educated person, or whether you're not, it doesn't matter. because it can happen to anybody. And I think somebody's opening statement said that it can happen to anybody. So it's important to just appreciate that none of us are immune to anything when it comes to health, right? We just have to do our best to take better care of ourselves and manage what we know to be the risk factors, which is why it's so important to learn about these things early on, so we can understand how to better lower our risk of developing something like dementia.
And just about any form of illness, the earlier we know about the problem is the better for us. So it's always important to detect these things early. What advice would you give to caregivers as relates to management and care of someone living with the disorder?
Right, so that's really a good question, Joy, because caregiving is very complicated. And then because there's a lack of awareness, generally speaking, within society, many people are typically left without the support and really direction. And I want to start off in answering that question in terms of support from the point of diagnosis as well, right? So we really, here at Stride, we encourage caregivers to speak to your doctor, because sometimes when the doctors are communicating information to us, they're using medical jargons that really go over our heads, right? So it's very important for you to just be very assertive when you're speaking with your doctor. Ask for clarifying questions. Ask them to specify the type of dementia, the medications used to treat it, dosage, if something is being prescribed, and write everything down so you don't forget it. And then it's also hard in terms of with your family. So in terms of support, we usually encourage persons as well. Call a family meeting, talk to your close relatives and your friends, people who you actually trust, to make sure that everybody is on the same page and is aware of the changes that your loved one is currently experiencing and will continue to experience. And just encourage them to learn about the disease, etc., and find out about care options, because you can't just do it by yourself. As you mentioned, it can be very, very, very challenging. So seek counseling, get help at home. Sometimes something like that is not affordable. So sometimes what we also do is encourage others to talk to each other, because it's really powerful when you have a space where others with similar experiences can share. You don't feel alone, you feel less isolated, and you feel supported. Additionally, for caregiving, we advise carers, yes, you want the best for your loved one, but you need to want the best for yourself as well. So you need to take a break when you're caring. You need to ensure that you have people to rely on. Rochelle spoke about risk factors as it relates to persons living with dementia. Carers themselves have to consider that. So you need to get enough sleep, at least 7 to 9 hours worth of sleep. You need to eat properly. Sometimes we hear at work, even people in this virtual space right now, you go on and on, you forget to eat. We need to eat healthy, we need to exercise, we need to take time for ourselves, figure out what works for us, even if it's listening to music. Monique, I believe earlier, talk about chronics. If that's what you like, take the time out. So carers also need to prioritize themselves, they need to support themselves, and they need to seek others to help to cushion that, to help to provide them with the confidence to give care to their loved one, etc. Because caregiver burnout is a real thing. Stress is a real thing. Rochelle spoke about that, and we want to ensure that we're properly caring for ourselves before we can care for others.
Thank you very much for that response, which brings me now to our next panelist, Mrs. Green Daly, because she lives with it every day. Mrs. Daly, could you just tell us what is your experience like at home, living with someone who actually has the disorder?
Okay. It has moved from mega stress to enjoyment.
Wow.
At the onset, not having the knowledge that I now have, it was totally challenging. You talk about burnout, caregiver burnout. Oh, I was burning at all ends. But as time progressed, I did some research. I have a very good GP and have good friends. And I'm not afraid to talk about it. I'm not ashamed about it, the whole situation. So I'm good to ask and to do reading and any little research to get any information. So as I learned more, I found out that I was able to cope better.
Okay. Thank you very much for that. So Dr. Phillips, in Ms. Robinson's response, she spoke about some treatment. Can you help us to understand if there is a cure for dementia? If not, what are the kind of treatments that a patient with dementia would need to take? Anything that we can get over the counter, or everything has to be prescribed?
So when we discussed it earlier, I mentioned that there were some conditions that would mimic dementia. So certainly, if you have vitamin deficiencies, hormonal problems, infections, etc., those are things that can be treated depending on what the actual problem is. So if you have a thyroid issue and you just replace your thyroid hormone levels, that may be all that you need. If you are depressed and it is looking like dementia and you're treated for depression, then of course you'll improve. But when we talk about the primary causes of dementia, which include Alzheimer's to the greatest extent, and the other types that we mentioned, there's no cure really for these. There are medications that we will give to slow down the progression of Alzheimer's, for example. But these medications are not in any way designed as curative. So we generally will tell the patients and their families that, these medications help your relative to be more like themselves for a longer period of time. So we tend to like to institute them early on when they're at the mild cognitive impairment status. And as they get more severe, there are others, fancy names, NMDA agonists and so on, that we use. But again, these are not curative. They just help to delay the progression of the disease. There is no cure for the degenerative causes, for the Lewy body dementias, for the frontotemporal dementias. There is no cure for those.
Okay. Thank you very much for that. Ms. Amor, what percentage of the aging population has dementia? Are women more susceptible to dementia than men?
So Alzheimer's Disease International, which is a huge NGO that does a lot of really interesting research on this around the world. They found that someone develops dementia every 3 seconds globally. Over about 50 million people worldwide are actually living with dementia. And this number is projected to double almost every 20 years because, populations are getting older. And so because age is such an important risk factor, it's very likely that this is going to really increase this challenge that we're facing in terms of dementia prevalence. For Jamaica, in 2015, there was an estimate done that about over 40,000 persons living with dementia in Jamaica. But in the Caribbean, we and in other developing countries, we know that this is likely to be an underestimation because there are low rates of diagnosis. If you go to the doctor and you complain about certain symptoms or something that you're seeing, and as I think Janelle mentioned, research shows that GPs do not, they think it's a normal part of aging. If they don't identify it and we don't really diagnose it because we think it's just how it goes when you're getting older, you're not going to report it. So we actually are not sure what the exact figures are for Jamaica, but we do know that it is a growing challenge around the world, especially in Latin America and the Caribbean region. We actually are estimated to have the highest prevalence by 2050. When it comes to if women are more likely to get dementia than men, remember women do live longer, generally speaking, right? We have a longer life expectancy. And because, again, age is an important risk factor when it comes to dementia, especially Alzheimer's disease, the numbers do show that more women live with dementia, and this is coming from the World Health Organization. But it's also important to remember that women are also most likely to be the carers of persons living with dementia. So when we talk about those living with dementia and caregivers, we're talking mostly about women. Not to say that men are not in the mix and that they do not also need to be included in the conversation, but we do have to think especially about women and how we can better support them and help them to lower their risk factors.
Miss Bennett, Nurse Bennett, are you back with us? So I was asking for you to just basically give us your experience looking after patients with dementia at an institution where you may have multiple patients at a time that is living with that disorder.
Okay, at an institution, at times it can be very complicated because there are persons with dementia, but sometimes they operate differently. You have some with different mood swing. Some will be calm, some will not talk, some will wander around.
What are some of the, outside of Alzheimer's in Jamaica here, what are some of the other types of dementia that you see coming to you? You're muted.
Yeah, so the main other type would be vascular dementia. Again, there are persons who may have like the frontotemporal part of the brain being affected by stroke or some head injury or something, who may have frontotemporal dementia. But the main other type would be vascular. So we mainly see Alzheimer's and vascular dementia.
Okay. And that one seems to be very widespread as it relates to Alzheimer's being the number one type of dementia.
Even though
globally,
I should say that yes, it's the most common cause of dementia, but really it's a post-mortem diagnosis, usually to see the changes in the nerves or the neurofibrillary tangles. You usually would see them at autopsy. So as I said, the diagnosis is made based on clinical features, screening tests, and the presentation of the patient for the most part. There are familial predispositions to Alzheimer's, which we are also aware of.
Thank you very much for that answer. Ms. Amor, what tips do you have to persons to help them reduce the progression? Because we learned that some persons start very mildly and it progresses into very serious waters. Is there something that we can actually do that is going to slow the process?
So I think Dr. Phillips would have touched on the role of medication and the fact that there is no cure, and that if it is indeed dementia and not another condition that's causing the symptoms of memory loss, etc., there is no going back. But for Alzheimer's disease, for example, there are medications that may be able to slow the progression of the illness. However, as far as I am aware, and Dr. Phillips can correct me as needed, it is going to progress. So there's really, it's a progressive disease by nature. So there is nothing that you can really do to stop that. The key that a lot of our work that we do with Stride is about managing that, managing the progression of the disease, understanding how the symptoms might change depending on the stage of dementia that the person is in. I see there's a question in the chat talking about, repeating stories and forgetting family members, and that's an indication of the progression. of that disease. So you would have to discuss with your doctor around your medication options in terms of possibly slowing the progression of it. But that is not really something that we have much control over because of the nature, the degenerative nature of dementia. There are things we can do to try and prevent it, but I think we've touched on those already as well.
Okay, because for example, since I now have a relative that is now diagnosed with dementia, we were told that we can use coconut oil because persons say that they have seen it work miracles in their relatives. I don't know if it's just man over matter, but you'll hear these things that you can get stuff to slow down the process.
Yeah, in our
yes, go ahead. Sorry.
In our research, we do come across that. There are a lot of home remedies that people swear by, but in terms of but in terms of from a research standpoint, and I can ask Dr. Phillips to speak on from a clinical standpoint, but from a research standpoint, there is not sufficient evidence at this time to suggest that it does have that impact. So we tend to stick with what the evidence is saying, and it is always changing because it's science and it's research, and we learn more and more every day. But there's still so much that we don't know about dementia. So we really try to support in ways that we know can help people.
Okay, thank you very much, Mrs. Daly. How was your relative's dementia detected, and what were some of how was your relative's dementia detected, and how quickly did you do something about it?
Okay, I lost a bit there. I just changed device.
Okay.
Yes.
You want me to repeat the question, or you got it?
I got it. Thank you.
Okay.
Well, we didn't have a formal testing, so you know something was going odd. So I just assumed that it's just a natural part of aging. Just learning, listening to the doctor today, I'm learning now that possibly this could have been reversed had we known that there was this progression, because we just heard dementia and Alzheimer's, but it wasn't very long. We didn't get formal testing. We just took it one day at a time.
Okay. Nurse Bennett, at your institution or in general, are nurses given a special training for dealing with patients with dementia?
Are trained, and also we do care plan as also to assess them and to take care of them at my institution here.
Okay, thank you very much. Ms. Robinson, is there a support group for dementia in Jamaica? Do you know of a support group? Are there plans for one?
Okay, right. So in terms of the support group, so Stride, as you know, have been around for a few years, and from our research and our continuous reconnaissance, we know that there are small pockets of persons that have independently started their group. So for example, we're aware of a foreign-owned company here in Jamaica that provides a support group for family members caring for their loved ones living with dementia. We are also aware of another group, I believe it's in St. Anne, which is a small private support group. But as it relates to a nationwide official support group, no, we're unaware of that. But as I said before, what we encourage persons to do is to just reach out to your networks with people who have similar experiences. Additionally, at Stride, because we are aware of the lack of support, one thing that we do and we do offer is free dementia care consultations for carers to help them to navigate the care experience, kind of prepare them rather for what to expect, help to build their confidence when they're going to their doctor's visits, when they're speaking with their loved ones, etc., and how and to encourage them to take care of themselves. So in terms of support, we're unaware of any national support group. Persons come together from time to time and they form their own, and we do our part here as Stride as well.
Is there, I know you have Cancer Awareness Week, you have all various kinds of illnesses, diseases have different days and weeks and months. Is there something for dementia, like a dementia week, a dementia month, that
Right.
special focus is given on that illness?
Right. So September is recognized as World Alzheimer's Month, and September 21st is recognized as World Alzheimer's Day. So during that time, we're really on a campaign to push awareness. We do it throughout, but during that time, we often call for persons to wear the color purple, you know, just to represent and to raise awareness. So when persons ask, so why are you wearing purple today? You know, that's an opportunity for us to share, like, okay, this is dementia, most common type is Alzheimer's, etc. So yes, there's a designated month and a designated day, which is September and September 1st, respectively.
Do we need to have specialists, or are there specialist doctors that deals with patients with dementia, or just the regular general practitioners? I guess Dr. Phillips could also assist here.
So generally, it would be a neurologist who would be, dementia would fall within their area of specialty.
Right.
But any internal medicine specialist is also trained in these kinds of illnesses and can appropriately and adequately diagnose dementia. General practitioners, yes, to an extent, but for really a more extensive evaluation and diagnosis, it would be best to send that person to a specialist.